I'm here to speak to you about neonatal head ultrasound. Here are my disclosures, and really the most important disclosure is that this is modeled off of a talk by one of my partners, Dr. Kristen Fickenshire. So for the learning objectives of this talk, I want to review the technique, review normal anatomy, compare normal anatomy variants versus pathology, and then go through a number of illustrative cases. So first I want to talk a little bit about technique. I want to talk a bit about where the windows are that we're imaging through. So really there's two common windows where we image. One is the anterior fontanelle, and then one is the mastoid fontanelle. It's possible to also image through the posterior fontanelle, but when you image through the posterior fontanelle, you can only do it on a preterm baby or very early in life, because that usually closes quite quickly. For our scan technique, what we do is basically we use a curved probe through that anterior fontanelle, and we acquire both coronal and sagittal images. And we acquire those in succession where we're going through multiple planes, as I'll show on the next slide. The next thing we do is we take that curved probe and we move it to one of the mastoid fontanelles, and this really gives us a good look at posterior fossa structures. And this is the one thing that I see community hospitals don't do quite as much as us, is really image through that mastoid fontanelle. But I'll show you a few illustrative cases where we found that really helpful for posterior fossa pathology. And finally, what we do is we use the linear probe, and that gives you a really good look at the subarachnoid spaces, the subdural spaces, helps you differentiate between those fluid collections. And additionally, it gives you a really good look at those three layers of the brain, so the pia, the gray matter, and the white matter, which should have all different echogenicities. So here's an imaging plane. This is from an review article by Harris Cohen. And basically it shows you what you should be doing in the coronal and the sagittal planes. So in his article, he recommends 6 standard images through the coronal plane and 3 standard images through the sagittal plane. And here are some rules of normal anatomy as we're looking through these scans. Try to keep these in mind, because these will really help you interpret these exams that for some of us are infrequent. So make sure that gray matter looks like gray matter, white matter looks like white matter. Ultrasound is really good at differentiating between tissues, similar to MRI. So you should be able to see gray matter, you should be able to see white matter. Ultrasound is an amazing technology for this differentiation between different tissue characteristics. Remember that normal is symmetric, but symmetric is not always normal. Remember that you should see the 3 distinct layers of the pia, the gray matter, and the white matter. And then remember that you can see this periventricular white matter, and it should be hyperechoic, but it should be relatively homogeneous, it should be relatively symmetric, and most importantly, it should be less echogenic than your choroid plexus, which is generally the most echogenic feature that you'll see in the neonatal head. So in your syllabus, I put a whole bunch of slides in for different imaging planes in the coronal and just pointed out the normal anatomy on those slides. And I just want to highlight 3 of these slides in each of these planes for you. So the first one is, I want to highlight the slide where you're doing a coronal image, but you happen to catch the posterior fossa. And really, in this image, you should be catching your circle of Willis and your cerebellum all in one slice. And you should see this dancing lady that's depicted right here. And that's really that circle of Willis here, and then your cerebellum there. One thing that you should note is this cerebellum should always be relatively homogeneous. She should have a clean dress, no spots. And there you see a spot, and this turned out to be a cerebellar bleed on the subsequent MRI. So just be really aware of this area, because it's an area that's tough to make diagnoses, especially if you don't have an open mastoid fontanelle or you didn't happen to scan through it. Finally, the caudothalamic groove on the sagittal image is really important. As you know, this is where most of your germinal matrix hemorrhages start because of the friability of the caudothalamic groove area. And here's your caudate, and here's your thalamus. And that's one of the last things I'm going to say about grade 1, 2, 3, 4 interventricular hemorrhage, because this is the one thing that I feel like they've taught everybody really well in residency, is to identify grade 1, 2, 3, 4 hemorrhage. So here's one of the linear probes. So when you're using that linear probe and you're looking at the grayscale, you really want to see this nice echogenic line that corresponds to the PIA. You really want to see this hypoechoic area that corresponds to your gray matter, and then your white matter should be relatively hyperechoic. For your screening Doppler, what we do now is we just do screening Doppler of the arterial system, and we like to see part of that dancing lady. So kind of this pentagon here, which is your intact circle of Willis, and then some of the arteries are labeled there. For venous Doppler, we do a few more screening sections. So first we do the anterior fontanelle via the sagittal plane. You can do it with a linear probe here, as we've done here, when we're trying to look for like more subtle flow. So two things to pay attention to are the superior sagittal sinus here, and then the vena Galen there. And if you're at all uncertain, you can always do spectral Doppler, as we did here, to demonstrate that there's definitely flow in these areas. The other thing that I recommend you do that is not, that again I don't see routinely done by more community practices, is scanning via the mastoid fontanelle and demonstrating flow within these transverse sinuses. So I've given you the cerebellum and the midbrain here that are labeled so that you can easily find that transverse sinus. Another thing that we can do is if we're suspecting hypoxic injury, what you can do is you can screen with power Doppler in addition to color Doppler. And basically what that will get you is on a normal scan, you should really just see those large arteries of the brain, those areas with normal arterial flow. But if you have an area of hyperemia, you'll see hyperemia all through the parenchyma and not necessarily confined to these vessels. And now I want to go through a set of normal variants versus pathology that looks relatively similar. So here is a normal variant that we see all the time. So this is premature sulcation. So this is a premature infant who is born maybe at 24 or 26 weeks of gestation, and you'll see this nice smooth cortex. And what you can do is you can actually kind of date some of these kids. So you know that the sylvian fissures form just past 24 weeks. And again, this occipital parietal fissure is seen at about 24 weeks. So if you see these two structures already formed, you can hypothesize that they're already past 24 weeks. When you get closer to term sulcation, what you note is that cingulate gyrus forms at about 28 weeks. So if you see this cingulate gyrus, you can say that they're likely past 28 weeks adjusted gestational age. And then your sulcal branching occurs at about 30 weeks. Here's an abnormal child. So you're already seeing some of this sulcal gyration. So since you see this sulcal gyration, you don't see that cingulate gyrus here. This might be confusing, but if you were able to scan through real time, you would realize this is the choroid plexus and not the cingulate gyrus. And so this was agenesis of the corpus callosum, which was confirmed by MRI. And so again, just look for these gyri that you know that should be there. And if they aren't there, that should kind of pique your interest and have you look further into things. Because after all, head ultrasound, neonatal head ultrasound is really a screening exam. And so if you see anything abnormal, please have a low threshold to move on to more correlative imaging to make a diagnosis. Here's another normal variant. If you're used to looking at neonatal heads, you'll notice this all the time. Cavum septum pellucidum. Sometimes this persists into adulthood, and we see it on teen and adult MRIs too, but typically it closes by 3 to 6 months. And here again, the cavum septum pellucidum in a sagittal plane. You see choroid plexus, third ventricle. You see the cerebellar vermis here. And this is another normal variant, just a normal cisterna magna. So if you can remember, this normal cisterna magna should measure about 3 to 8 millimeters in that sagittal plane. If it measures more, you can, again, investigate more into what's going on. And so if that's a normal variant, this is your corresponding abnormal. So you see a posterior fossa fluid collection. So here, not only do you see some fluid between the vermis and the occiput, you see some fluid that comes posteriorly. And so your differential diagnosis for all of this posterior fossa fluid is going to come down to 3 types of things. One is a megacisterna magna, where basically you just have a large large cisterna magna. The second is an arachnoid cyst. And this is an arachnoid cyst because you see that there's mass effect on the vermis. This vermis is displaced anteriorly. And so once you see mass effect, you really have to start thinking along the lines of an arachnoid cyst. Finally, look very carefully at your cerebellar vermis if you have fluid back here, because if there's any uplifting of the vermis, or the vermis is only partially present or is completely gone, you really have to question whether you have a Dandy-Walker variant, such as a Blake pouch cyst or a full-on Dandy-Walker malformation. And again, MRI is your friend here for correlative imaging. So here's another normal variant that we see a lot, and that's asymmetric lateral ventricles. So you see this in about 20 to 40% of infants, so this is really common. So please just be careful. Look for mass effect, look for, again, those 3 layers of cortex, look for differences in the white matter. But if there's none of those things there and you just see isolated lateral ventricle asymmetry, it's probably okay. And the lateral ventricles tend to get smaller as that infant matures, and then normal is less than 10 millimeters. So if you see something that's greater than 10 millimeters and you see this copocephalic configuration of the ventricles, that's when you really have to be concerned. And really you're going to end up in a broad differential here, a Chiari-2, PVL, agenesis of the corpus callosum. Again, you'll probably be able to differentiate between these to put something on the top of your differential by ultrasound, but in the end, the treating physicians are probably going to want an MRI to confirm and to make evaluate some of the prognostic indicators associated with these. So here's one thing that I've struggled with until I became an attending, and I saw enough of this. And this is basically this hyperechoic white matter, because we're always concerned for periventricular leukomalacia or periventricular injury. And so one thing that I learned from my fellow attendings is you really want to see this lesion in 2 planes. So here's one where you see some of this hyperechoic white matter just adjacent to the ventricle. But once you turn on it, it looks normal. And this is what's really reassuring. And I didn't realize. I was really overcalling this by just looking at it on 1 plane. I really should have been looking at it at 2 planes. And now I'm much better about being more sensitive and specific about real white matter pathology. And so here's something that's abnormal. So you see this echogenic white matter here. Now we turn on an oblique view. It's still there. Even better, we did a 3-week follow-up. And again, it's still there on that oblique view. It's actually gotten probably more confluent, and we're seeing some areas of cystic change. So this is true periventricular leukomalacia, true periventricular white matter injury. And again, here's more of that normal variant, kind of this periventricular halo. So when you see this periventricular halo, again, your white matter is supposed to be bright relative to your gray matter. And this central white matter tends to be brighter than the peripheral white matter. And again, it's normal echogenicity compared to the adjacent choroid plexus. So that, again, your choroid plexus should be your most hyperechoic structure that you see in the brain. And this white matter is less echogenic than this choroid plexus. Look for asymmetry here, or look for this white matter starting to be even more echogenic than your choroid plexus. And so we see that on this one. This is asymmetric, increased echogenicity. On the 24-hour follow-up, we see this has gotten larger, and sure enough, this turned out to be a bleed on this kid on ECMO. And here's the final normal variant. It's lenticular striate vasculopathy. Again, it's these branching areas within the thalamus. It's really commonly seen. Initially, the papers came out and said it was associated with all these things, but again, they didn't look back at the controls. So when we actually went back and looked at normal controls and normal neonates, it was seen there as well. So it's not a very specific sign of disease. And so now in peds, we tend to call this more of a normal variant than any indication of these specific diseases that were initially identified by the initial literature. And so now I just want to go through a few cases with everybody. So here's case 1. It's a 5-year-old term infant. Which of these cortices is abnormal? So we have images of the right and left cortices, and in this left cortex, you can see this nice echogenic line. You can see that you can differentiate the gray matter from the white matter, and here you've really lost that differentiation between the gray and white matter. So this turned out to be a right MCA stroke, and this violates that rule. You really should see 3 distinct layers of brain, including PIA, gray, and white matter, and you don't see that in this case. Here's another case, 2-year-old male with seizures. Where is the lesion? So again, this comes back to that lady's dress. This is actually the posterior fossa bleed. So really there's a small hypoechoic region on that area that's not on the other side. And again, it's relatively heterogeneous back there. Here's your correlative MRI with the susceptibility weighted image, which shows that bleed really well. And then one thing that we were really glad we did, because we missed it on this initial exam, was we did a mastoid fontanelle view, which showed that bleed much, much better, and it was way more obvious there. And so then we could correlate back here and say it was there on the coronal as well. This is a 6-week-old with group B strep. What's the diagnosis here? What's the abnormality? So again, here we're looking at those 3 cortical layers, and this is the one thing I really want you to get out of this talk, is those 3 layers are really important, and those are more of the subtle findings that you're more likely to miss. So this is cortical laminar necrosis. So again, you just have this hyperechoic cortex that's there, and that really shouldn't be hyperechoic in that gray matter. It should be hypoechoic. So again, this cortical gray matter is kind of looking more like this periventricular white matter, and again, that's what should have tipped us off to the diagnosis. So here's another question. 2-week-old male, what's the diagnosis? And again, we just have to remember where the gray matter is, where the white matter is. So we have these deep gray nuclei here. And again, gray matter should be hypoechoic. And in this case, it's hyperechoic with some mass effect and some enlargement of the lateral ventricles, which again, can help tip you off to look for these parenchymal abnormalities. Here's a nice head CT showing that large parenchymal bleed within the thalami. And this was due to venous thrombus. And again, basal ganglia gray matter is just way too echogenic here. It looks more like white matter, and that should never be the case. Here's another one, 1-week-old male, and we're looking for a diagnosis here. And again, this is nice because I've given you the coronal and sagittal, and in the coronal you see some white matter asymmetry. In the sagittal you can confirm that. And so this was actually a focal ischemia and stroke. And again, the white matter asymmetry, and it was brighter than the choroid, and this is confirmed nicely on the corresponding MRI. Here's a 6-week-old. I think this one's probably the hardest case that I'm going to show you. And so here again, we're looking at those 3 layers of cortex, and we're looking at specifically at the insula here. So on this side, you see the nice insula, you see the nice gray matter here. And on this side, you've really lost it with loss of that gray-white differentiation. So this is an MCA infarct. You see that normal insular cortex on this side, and you just see loss of that nice insular ribbon on that side. And finally, this is a 4-month-old with macrocephaly. And this is one of those really common boards questions. So the diagnosis really here is child abuse. So again, the concept is these linear images are really helpful to differentiate between what's happening in this extra-axial space. So you have these subdural fluid collections here, you have these subarachnoid collections here, and you have this nice membrane between the 2 of them, separating your subdural space from your subarachnoid space. What's really helpful here is if you do that color Doppler imaging, you can see these vessels nicely outlined in that subarachnoid space. And in the subdural space, you should see none of those vessels. And again, you see fluid of 2 differing echogenicities here. One is hyperechoic fluid, hypoechoic fluid, so it suggests an acute on chronic component. And really here, you should be suggesting child abuse, and they should be referred to your child abuse doctors if you have them available. And finally, kid on ECMO for a large congenital diaphragmatic hernia. And again, with that history of ECMO, we look really carefully at that caudothalamic groove, but that caudothalamic groove is pretty nice. You see that nice kind of seagull shape there, and there's no bulging of that region, of that germinal matrix. And so really, it's, again, to emphasize, it's looking at those 3 layers of cortex. So you just don't see good cortical differentiation there. And this is diffuse cerebral edema. And this is a really difficult one. And it can be really difficult at MRI with that diffusion-weighted image too, just because some of these pathologies are so generalized that I've been almost fooled on a lot of MRIs where I'm looking at the diffusion-weighted imaging. And because it's just so grossly abnormal throughout, you're missing the actual findings. And ultrasound suffers from that same pitfall. So conclusion, I think the standard technique is really important. I would urge you to look at those articles by Harris-Cohen and kind of do that nice coronal sweep, that nice sagittal sweep, and especially do the mastoid fontanelles. Get your sonographers used to it so that they're doing it more and more and they feel more and more comfortable with it. And I think this emphasizes really that high-quality ultrasound is particularly important in this neonate. I showed you many cases where you really want to see those 3 layers of PIA, gray, and white matter. And I think that linear transducer is really helpful for that. And I think looking out for that in your day-to-day practice is really going to help you make a lot of more of these subtle diagnoses. Here's some references. These are 2 great articles that were published in the Ultrasound Quarterly Journal recently. And thanks for your attention.